Note the Dupuytren's contracture of the fifth digit. In patients with Dupuytren's disease, the pretendinous bands thicken and become pretendinous cords. These cords tighten over time and pull the finger inwards, as is the case in this patient. It has been in this position for almost 5 years. Extension of the proximal interphalangeal joint is limited, which is demonstrated well from a lateral point of view. The fourth digit is also affected, but not as extensively as the fifth, as the extension of the joints is not limited. The pretendinous cords feel thicker and more rigid than healthy tissue. Palpation can therefore be used to identify these cords. The area of diseased tissue is marked on the skin. The other rays are palpated to identify any diseased tissue in these rays. Note that both the palmar area and the digit itself are affected in the fifth digit, and that only the palmar area is affected in the fourth digit. Before starting the aponeurotomy, the location of the nerves and arteries should be considered. For educational purposes, the marking is removed and the most important arteries and nerves are now shown using an anatomical inlay. Note the superficial palmar arch, the median nerve, the superficial branch of the ulnar nerve, the common palmar digital nerves, the proper palmar digital neurovascular bundles, which run alongside the flexor tendons, and the communicating branch of the median nerve with the ulnar nerve. An anatomical layer is added and the pretendinous bands are highlighted. In Dupuytren's disease, these pretendinous bands are diseased and then called pretendinous cords. These cords cause the contracture of the finger. Note the close relation between the pretendinous cord and the neurovascular bundles. Care should therefore be taken to stay close to the pretendinous cord to avoid injuring these vital structures. During a standard percutaneous needle aponeurotomy, the puncture sites are located over the pretendinous cord in a longitudinal manner, 5 mm apart, as shown here. In this film, a more extensive percutaneous needle aponeurotomy is shown, as per preference of the surgeon. A much greater number of puncture sites will be used, approximately 0.5 mm apart, over the entire diseased area, as shown here. This way, the continuity of the pretendinous cord is more efficiently disrupted compared to the standard percutaneous needle aponeurotomy. The aponeurotomy is started proximally. Take note that the needle is placed perpendicular to the skin. A sweeping movement is used in a direction perpendicular to the pretendinous cord, hereby splitting a small part of this cord. This way, the point of the needle is used as a small scalpel. The puncture site is used as a hinge, and care is taken that only the point of the needle moves around this hinge, instead of moving the entire needle. In this film, a 20-gauge needle is used. Different surgeons may prefer different needles, but mostly in the range of 18 to 25 gauge. Note the opening of the needle. The needle is introduced in a way that a small part of this opening is still visible to avoid introducing the needle too deeply so as not to injure the underlying flexor tendons. Proprioceptive feedback is constantly obtained in the form of a gristly and firm feel and a concomitant scraping sound. When firm feedback at the needle tip stops, that specific area is sufficiently treated. The needle is removed and a new puncture site is used to split another small part of the pretendinous cord. This is repeated until palpation yields a soft feel. Note that the cord is tensioned by a second person using gentle passive extension of the affected digit. Alternatively, the surgeon can use the non-operating hand to do so, or a lead hand can be used. Tensioning the cord is very important as this moves the cord more superficially, which makes splitting the cord easier. Also, deep introduction of the needle is not necessary, thereby reducing the risk of injuring surrounding nerves or arteries. The palmar area of the fifth ray, now highlighted, is now softened. The procedure is continued on the palmar area over the fourth ray. An anatomical inlay is used to highlight the metacarpophalangeal joints. If spiral cords are present, these are located in the area near this joint. these cords may displace the digital neurovascular bundles, now highlighted, more superficially and centrally. Therefore, extra care is taken in this area so as not to injure these neurovascular bundles. When the needle becomes blunt, its effectiveness decreases. Therefore, the needle should be replaced frequently. The procedure is continued distally over the 5th digit. Care is taken to stay central to the pretendinous cord to avoid injuring the neurovascular bundles. Again, repetitive palpation is used to evaluate the effect of the aponeurotomy. The last rigid parts are then treated. Note that the surgeon is now tensioning the cord himself. After the entire course of the pretendinous cord yields a soft feel, the connections of the pretendinous cord with the skin will be transected. Note that this is done as per the surgeon's preference. The needle is used for the transection as well. Note that the needle is introduced from the lateral side just under the skin. The point of the needle is moved very superficially, just underneath the skin, as deeper introduction may injure the nerves or arteries in this area. The needle is bent as shown here, which makes staying superficial more easy. After all connections are transected and a plane is created between the skin and the underlying pretendinous cord, the finger is examined. Note that the metacarpophalangeal joint and the proximal interphalangeal joint can be extended, which was not possible preoperatively. In this case, the surgeon applied a cast postoperatively for 1 week to passively extend the finger, as this patient had a contracture for almost 5 years. This is done in order to disrupt the memory of the contracted position of the joints. Whether or not this is done depends on local postoperative care protocol and the preference of the surgeon.